A young patient comes at night to the emergency department. Wheezing, chest tightness, struggling to breathe. By morning, he is completely fine. Normal lungs, only a few hours later. So what exactly is happening inside those airways? I'm Nabeel and this is Pathogenesis. Today we look at bronchial asthma. Asthma is chronic inflammatory disease of the airways with airflow obstruction, which is reversible due to hyperresponsiveness of the airway. Asthma is not just bronchospasm, it is hyperreactivity plus inflammation. What makes bronchial asthma unique? Asthma occurs only in response to a trigger like pollen or dust. And it is episodic. Unlike chronic bronchitis or emphysema, which is persistent. And as we have seen earlier, it is reversible. Between attacks, lungs may be completely normal. This brings us to the types of bronchial asthma. First type is atopic. This is the most important. This is classical allergy. It is an allergic response to dust, pollen, etc. and is IgE mediated and is a type of type 1 hypersensitivity. This is usually a childhood onset asthma and patients have family history of allergy or asthma. The second type is non-atopic. Here there is no allergen and is usually triggered by viral infections, pollution or cold air. Third group is drug induced, mostly aspirin or other non-steroidal anti-inflammatory drugs. It's thought that here because of aspirin, prostaglandin E2 reduces and since the inhibitory effect is gone, leukotrienes increase and this triggers asthma. Fourth type is occupational. Here asthma is triggered as a response to chemicals, fumes, dust, etc. Different triggers, same airway response. Now let's look at the pathogenesis of asthma. The first step is always a trigger. Trigger can be dust or pollen or viral infection or anything. Trigger starts with the antigen reaching the airway. This antigen is taken up by dendritic cells and these dendritic cells present these antigens to T cells and specifically here the Th2 cells. And the Th2 cells present these to B cells. Along with that, the Th2 cells also secrete interleukin 4. This forces the B cell to produce IgE later on. These B cells convert to IgE secreting plasma cells, which secrete IgE. The IgE goes and binds to mast cells. The Th2 cells and the mast cells produce interleukin 5, which attracts eosinophils to these areas. Now everything is set up. The bomb is ready to explode. This was the trigger phase. Now let's see what happens in the immediate phase when the allergen reappears. When the allergens come again, they are picked up by the IgE on top of mast cells. And once this happens, the mast cells degranulate. This leads to increased vascular permeability and edema. and increased mucus secretion, and smooth muscle contraction leading to bronchoconstriction. All of this happens within minutes. Within a few hours, we enter the late phase where inflammatory cells come into the picture. Eosinophils, neutrophils, and basophils come and they release their mediators, which leads to damage to the mucosa and more mucus secretion and increased bronchoconstriction. So early phases bronchospasm, while late phases inflammation. Due to repeated attacks, in the long run, airway undergoes significant changes in bronchial asthma. Let's see what are those. Compared to a healthy airway, in bronchial asthma, goblet cells are increased and there is increased production and accumulation of mucus. The basement membrane becomes thickened when compared to normal airways. Inflammatory cells are very much increased, composed of neutrophils, eosinophils, lymphocytes and macrophages. The smooth muscle cells increase in number and size. So hyperplasia and hypertrophy of smooth muscle cells. The submucosal glands increase in size. So overall, in the long run, almost everything increases. Increase mucus, increase goblet cells, increase inflammatory cells, increase in smooth muscle cell thickness, and increase in submucosal glands. These changes takes asthma almost into an irreversible territory. That is why there is considerable overlap between all of these obstructive lung diseases. Now that we have seen the pathogenesis of asthma, let's look at the morphology. Morphology has been described in patients who have died of status asthmaticus and also in mucosal biopsies of patients with asthma. In fatal cases, lungs are distended due to air trapping along with mucus plugs which occlude the bronchi and bronchioles. And these mucus plugs contain shedded epithelium which are called Kirschmann spirals. Another characteristic finding is charcot-laden crystals. Along with these, you get all the findings which we discussed earlier, including increased mucus, increased goblet cells, thickened basement membrane, increased inflammatory cells, smooth muscle cell hyperplasia and hypertrophy of submucosal glands, etc. Clinically, patients present with the classical symptoms of wheeze, dyspnea, cough, and chest tightness. And asthma is most often exacerbated in the night or early morning. The most severe form of asthma is called acute severe asthma, or earlier called as status asthmaticus. This can be even fatal. Asthma is the only obstructive lung disease which can completely reverse until it doesn't. Repeated attacks may change the airway permanently. That is why early control of inflammation is very important. Think at the cell level.